chief of endocrinology at the School of Medicine here. And Orthopaedics called me a couple weeks ago, and they were looking for someone, begging for someone to do a talk on osteoporosis for you. And I volunteered, so here we are. But it's good, though, because you know why? It's a very common disease, as you're going to find out. It's very important. A lot of people don't think about it, but when you put it in perspective to other adult illnesses, it's much more prevalent, much more common. And it has very severe, very dire repercussions to patients who fracture bones. So let's see here. So this is World Health Organization says osteoporosis is a disease characterized by low bone mass, structural deterioration, leading to bone fragility and increased susceptibility to fractures, hip, spine, wrist, although anywhere could be affected. NIH says it's a skeletal disorder of compromised bone strength predisposing to increased fracture. Because when it comes right down to it, you don't really care if the bones look weak, feel weak. What you really don't want to have is a break. So the ultimate criteria for this is fracture. We want to avoid fracture with patients who, as people get older, and to prevent fracture from osteoporosis. Who gets this? Well, this is a little bit older slide, and the numbers are exponentially increasing as our society gets older and lives longer. But here, 52 million Americans are at risk for osteoporosis, 9 million women to almost 3 million men, 40 million are in the low bone mass. So clearly, you could be normal, which is great. You could have osteoporosis, which is bad. But to get to osteoporosis, you had to be somewhere in between for a while, and you're moving that way. And we have 40 million people in that category, many of which are going to become osteoporotic over the course of years. In terms of all diseases out there for adults, you can see that osteoporotic fractures, 1.4 million in women, almost 600,000 in men. But that far outweighs heart attacks, prevalence of strokes, breast. You put all these three together, and they don't even add up to how many osteoporotic fractures that women get in a year. In men, osteoporotic fractures and heart attacks. Of course, men get a lot more heart attacks, stroke, prostate cancer. So again, even for men, osteoporosis is a severe disease, and it's a prevalent disease. So you have to keep that in mind. You just don't say, oh, it's only a disease of older women. That's not true. In terms of the type of fractures people get, vertebral fractures are the most common. Wrist, fall down, you break your wrist because the wrist gets, distal forearm gets really weak, and hip fractures. So if you look at this up here note where it says 50% of women over the age of 50 will experience an osteoporotic fracture in their lifetime. That's a huge number. And 25% of men over the age of 50. And if you break something, it's a bad thing, especially if you break your hip, because there's an increased risk of dying in the next couple of years just by having done that. In addition, the older you are, the less likely you are to recover sense of autonomy. You may never walk again, may end up in a nursing facility. It's a very, very bad disease if you fracture your hip. And if you fracture something, it begets other fractures. So women who fracture a hip are much more likely to fracture the other hip. So just because you fractured one, you really need some kind of intervention to reduce the fracture risk on that other hip. The sad thing about a lot of this is most osteoporosis is silent. It's silent till it breaks, so you wouldn't know you had it. If you say, oh, my back hurts, is that osteoporosis? It's probably degenerative arthritis. But once you break a vertebral fracture and crush it, that hurts a lot, and that's a different type of pain than the run-of-the-mill aches and pains we get as we get older in our joints and in our back. So typically, there is no pain until it breaks, and that's a really bad thing. The way we diagnose it is with bone mineral density testing, and we'll talk a little bit about that soon. If there's any questions along the way, feel free to interrupt, and we can stop and go over something if it's a burning question. And this says that if you break your vertebrae, so the crush fracture of the vertebrae, you're much more likely to break others over the course of time. You're a very high-risk category. And this just shows, again, that the hip fracture is devastating. 10 to 24% excess death rate in the year following a hip fracture. 30% of people end up in the long-term health nursing home facilities. And again, it's just hard to recover from that type of fracture. And the older you are, the more difficult that is. Surgeon General's report said a lot of people are at risk for bone loss and osteoporosis, that we're doing a lot better in terms of trying to prevent that. So we do things to try to prevent that. When you see your doctor, are you taking calcium, are you taking vitamin D? Do you have any other factors that predispose to osteoporosis? Can we prevent loss of bone density along the way some way? So we are doing better that way. The risk factors are, if you already have if you're already in that low bone category, your risk for progression is higher than patients who have, or people who have normal bones. Additionally, the older you are, obviously that's a risk factor. If your mom or your dad had severe osteoporosis, that puts you in a high-risk category. If you are a woman who had their ovaries removed and never put on estrogen replacement therapy years ago, that lack of estrogen predisposes to loss of bone mineral density. Some of you may remember this World Women's Health Initiative that was published in like 2000, 2001, and they said, oh, this hormone replacement, estrogen replacement therapy is horrible for women. And everybody's getting breast cancer who's on this, and they're all dying from heart disease, so you shouldn't use it. And so basically everybody got a big fear factor. The doctors wouldn't prescribe it, women didn't want it. As it turned out, when they re-reviewed the data, the younger women in those groups were okay with that and actually had reduced risk of heart problems, reduced risk of invasive breast cancer, and the longer you were on the estrogen, you had a significant reduction in osteoporosis. So a real disservice was done by the initial reports out of that study. Now we're kind of coming full circle on that, and we're convincing women in the early menopause years to perhaps go on some hormone or estrogen replacement therapy. You hear a lot about low T in men, so that's clearly without testosterone, you lose bone mineral density. Ethnic groups, typically African Americans have stronger, heavier bones than Caucasians, Asians lighter than even Caucasians. Some people are on various medications like steroids. So if you're on and off prednisone for various reasons, for other health problems, it can really cause an abrupt deterioration in bone. Lifestyle. Let's see, I can tell you that all the adults I ever see, I say, do you take calcium? No. Do you drink milk? No. Take vitamin D? No. I measure their vitamin D level. It's in the toilet. That's just the way it is in Dayton, Ohio. And nobody likes milk. Nobody likes milk products. Nobody takes a lot of calcium supplements. Physicians now, primary care doctors, are much better at that, trying to promote those kind of healthy habits to improve or at least prevent loss of bone density. If you don't get any activity, if you were immobilized, or you act as an immobile person sitting around all the time, predisposes to loss of bone density. Smoking's no good for you. If you're real skinny, now you can't really genetically change that. Some people are just genetically thinner. That's the way they are, but they tend to have a higher risk of osteoporosis because if you don't carry a little weight around with you, your bones are thinner by nature and can lead to predisposed to osteoporosis. Physical activity, drinking too much, those are other lifestyle changes and factors that can predispose to osteoporosis. Falling. So what I would always tell patients that I see who are a little bit on the older side and they have poor bones or osteoporosis, if you don't fall, your chances of breaking the bone are a lot less. You have to be careful when you're older in terms of, and your balance may not be so good, your eyesight might not be so good, you shouldn't be climbing on step ladders, shouldn't be cleaning the leaves out of your gutter after a certain age. You have to be careful. And for people in this room who have elderly parents, if they have carpeting, loose carpets around their house, that's how people end up tripping over something, falling and breaking a hip or breaking their forearm. So those kind of things, fall prevention is really, really important. As people get older, this is the slopes of the curves of the fracture-related problems. So vertebral fractures you see rises here in the 50s. So the bone turns over faster in your spine than it does in your hip. And so because it's turning over in the net favor of loss all the time as we get into middle adulthood, you lose vertebral bone first, and therefore you're at risk of these fractures first because you're losing that density ahead of the hip, which trails behind by about 10 or 12 years. So people who break hips typically are 10 or 12 years older. They're more in their later 60s, 70s, 80s, compared to those who are going to fracture their vertebral bodies. And then we have a nice tool. And one of the tools we say is we have a density measurement. So looking at bone density compared to the average and then lower by standard deviation just means your bone density is lower. The lower it is, the higher your risk of fracture at any site, really. So there's a nice correlation with that bone density and your risk for fracture. And that's where we get the tool, that DEXA scan, for identifying those patients who have lower bone density, increased fracture risk, and make a diagnosis of osteoporosis. So the diagnostic technique that we do is a DEXA scan. Dual X-ray absorptiometry is the preferred method for diagnosing patients with osteoporosis. If your bones are so thinned out, you have a lower score. The lower the score, the higher the fracture risk. When you hit some threshold of low score, you have osteoporosis. If you have normal, you're normal, and then there's that in-between category that we call osteopenia, meaning the bone density is lower than it should be, but it's not osteoporotic. But you are at higher risk for fracturing even if you're osteopenic. So it's something to be taken seriously. Plus, to get out to be osteoporotic, you had to be osteopenic sometime. So that might be a good place to intervene in some patients. Sometimes you've gone to maybe, or you might have seen health fairs around where they do heel absorptiometry, ultrasounds, and those aren't as good as DEXAs. If you have a totally normal heel or super good bone in your heel, you're probably okay. Anything other than that, it's a wild card. You just don't know what the numbers mean. So I would stay away from that as a predictor of bone density. And this is where we are. This is what happens to us. We grow, our bones get stronger and stronger, we get good bone mass. We peak out at about 30 to 35 years old. Then what happens? Then our bones are on the slide. So most of the people in this room, like me, are on the slide. There's nothing you can do to stop the slide, really. So what you'd say to yourself is, boy, I wish I had a really high peak up here, and then if I start my slide, it's not so bad. And that's some of the idea behind getting younger people to drink milk, take calcium, get good vitamin D, younger bone health, so they build a higher bone density. So when they start that slide and they're out here in their 80s, they're still up here. They're still at pretty good bones. And there's an abrupt loss. So menopause, the first 10 years after menopause, women can lose up to 20% of their bone mass. That's where that hormone replacement or estrogen replacement was so valuable in stopping that slide, but we don't use it as much anymore since that Women's Health Initiative came out. And then even after that, there's a progressive loss of bone. The numbers that we talk about are standard deviations from the average. And if you are a minus 2.5 or less, then you have severe or minus 2.5 or less, you have osteoporosis. If you have the same scores and or had a fragility fracture means you did something that was just minor trauma and you broke your bone anyway, like stepping off a curb, stepping down off the last step of your stairwell, and you broke your hip just from that slight trauma. That's a fragility fracture. By definition, it doesn't matter what your density is, you have osteoporosis if that were to happen to you. If you have a -1 or above on that standard deviation, those are the T-scores on the DEXA scan that your doctors will talk to you about, you're normal. So that's great. If you're between a -1 and a -2.5, you have low bone mass or osteopenia. Still have an increased fracture risk, but not as bad as osteoporosis. Who should have a bone density study? It's really the question should be who should not have a bone density study. You know, everybody sooner or later should have one of these. So women 65 years and older are at high risk for osteoporosis. They need a bone density. They should have a DEXA scan to see where they stand. Men over the age of 70 should have that. If you're younger but you have other risk factors like you were really skinny your whole life, you smoked, maybe you're an alcoholic, maybe you're on steroids on and off for a long period of time, other risk factors that would predispose you for losing your bone earlier, you can justify doing that DEXA scan at 51 or 52 years old. If you have had a fracture earlier, you can do this. If you have other medicines that predispose to rapid bone loss, of which the steroids are the most commonly used that accelerate loss of bone density. So how do we prevent this? That's the big question, because there's a lot of people in the pipeline already, a lot of people with osteoporosis, a lot of people in the pipeline. So risk reduction is good, you know, changing your diet, that's good, getting adequate calcium, vitamin D. We'll talk a little bit about what you should be taking. Regular weight-bearing exercises. So if you don't walk around, your hips and your spine's not getting banged around a little bit, you're not putting pressure on your bones, they're not going to stay strong. If you say, well, I'm going to go swimming instead, swimming doesn't help your hips, doesn't help your long bones, because there's no pressure on them. It's great cardiovascular, so if you already have significant osteoporosis, you have a lot of joint problems, swimming is great exercise because you don't put a load on your bones and you get cardiovascular fitness. But in terms of improving bone density, it's not going to happen with swimming alone. Hi.
I found the place finally.
Come on in. We talked a little bit about fall prevention and balance training, so older people certainly can benefit from being more active, doing some kind of exercises, working on balance so that they don't lose their balance and fall and break anything. Smoking and excess alcohol usage also. Those are things that can be changed. We talk about what should you eat, calcium-rich foods, dairy products, fruits and vegetables, whole grains. Don't drink so much sodas, not great for the bones, potassium-rich food. But really the important thing on this slide, I think, is this. Older people don't go out in the sun as often. African Americans can't convert the sunlight to vitamin D adequately, so they're often very vitamin D deficient. If you do what the dermatologist says and apply your sunscreen before you go out, and everybody out now, there's SPF like 2,000 now, right? It used to be like it was like 10, 20, 30, maybe a 50. Now it's like 100. I don't know what it goes to. But if you're up over 10 to 15, you block virtually all the UV radiation to your skin, and you don't make any vitamin D. You don't get any improvement in vitamin D levels when you're wearing your sunscreen. It's not to advocate you go out there and get sunburned or anything, but if you went out for 2 or 3 minutes without sunscreen, maybe that would be okay in some people. But you have to watch what you say about that, or you get crucified by the dermatologists. So we would like to maximize that peak bone mass. So what does that mean for most of the people in this room? Most of the people in this room are over 35, so we're done. We're beyond our peak. But if we have children, right, especially young females who, when they get into adolescence, they don't drink milk, and nobody's getting enough vitamin D and date, maybe some of those changes could benefit them. But we can minimize our bone loss by doing those things that are good. That is, good calcium, good vitamin D, good exercise, weight-bearing exercise, those type of things to decrease our bone mineral density loss. And of course, there's medications ultimately, which we'll talk about. If you just look at general recommendations, somebody says to you, well, how much calcium should I take? I think if you just say 1,000 milligrams a day is good for about everybody. You could squabble over another 200 for over 50, but if you're not getting about 1,000 a day, you're not getting enough. So everybody should get about 1,000 per day, whether it's food alone, which is fine, or food plus supplements. Yes, ma'am. Well, if you get it in your diet as food, right, so like milk-containing products, that's probably your best bet. If you're taking calcium pills and you're taking calcium carbonate, you want to take that with food. If you don't take your calcium carbonate with food, you should take calcium citrate, which is absorbed better when there's no food around. You could take it with food too, sure. Yeah, that's a good question. You know, I didn't make these slides, and I was thinking about that myself, how potassium really would influence it. I'm sure potassium is incorporated into the mineralization process in some of the bones somewhere, but to tell you the truth, I actually looked at this slide just a while, and I said, I better not even say that, because if somebody asks me, I don't know what to tell them. And I actually don't really know what to tell you about that. I don't know who put that on there.
Is almond milk as good for you as cow's milk?
Yeah, as long as, all those are, if it's soy or almond and it has 300 milligrams of calcium per 8 ounces, it's good. It's all good, yes. And you can see here that most things, like your 8 ounces of yogurt, 8 ounces of milk, they all have about 300 milligrams of calcium. There's other foods, you could eat a lot of ice cream to get enough calcium. Here's your soy with added calcium. So a lot of foods have that, good calcium, but a lot of times as adults, milk-containing foods aren't high on our list. A lot of people get lactose intolerant as they get older. And so they don't take milk products in very well at all, in which case you really should be taking calcium supplements to make up the difference. So typically, if you don't get enough from food, which I think is a significant proportion of the population, you should be taking a supplement. How much you take really just depends on how much you figure that you get from your diet and how much should you add to that. And then all the products that have calcium in it have a nice label. Let's see if I have the label here. I do. So here, the back supplemental facts label will have how many milligrams of calcium are in there. And that's the elemental calcium. That's the important calcium number. Sometimes the bottle will say like 1,200 milligrams of calcium citrate. But the citrate part of the calcium weighs a lot, so you're not really getting elemental calcium in that number. So you should always look at the supplemental fact label on the bottles to figure out what you should take. And generally, calcium carbonate needs to be taken with food to help the absorption. Citrate doesn't really need that. Citrate's always more expensive than calcium carbonate. No, you don't necessarily. Usually if you have vitamin D in it, it costs more, right? So if you took vitamin D separately, it would be cheaper a lot of times. And a lot of times the calcium with the vitamin D doesn't have enough vitamin D to get your levels up to where you'd like them to be. So in my mind, I usually just tell them to buy the calcium, but if they buy the calcium citrate or calcium carbonate with D, that's fine, as long as the total amount of D also adds up to be approximately what an individual might need, which we'll talk about in a second. So people, could complain, and some people get constipated if they take too much calcium. Hopefully that's not the case. And then there were studies out there, and you probably saw this on the news, because this is one of these sensationalization things. It's kind of like when that Women's Health Initiative came out, that estrogens are really bad for everybody, they're killing them, and then nobody would use it. So somebody came up with this idea about calcium, not really doing a formal study, but going back and looking at groups of people and coming up with an idea or coming up with data that suggests that if you took a lot of extra calcium in your diet with calcium carbonate or calcium citrate, that group of people had some higher risk of cardiovascular problems. But it's not really a scientific study going forward to prove that. It's a retrospective look at data that wasn't meant to be that way. And a lot of it comes from hearsay, what the people think they were taking, what they recall they were taking. So it's not really scientific. I think most people would say, most bone experts would say, you shouldn't be afraid to take reasonable amounts of calcium. Vitamin D, in Dayton, Ohio, everybody I measure in my clinic, I would say 70–80% are significantly vitamin D deficient. Part of it has to do with you can't go out in the sun starting in the beginning of November up until the end of April. You won't get any significant skin exposure to sunlight if you choose to do that anyway. And so they have that 6–8 month time or 7-month time frame where there's no good sunlight to make vitamin D through your skin. Therefore, you need supplemental. That's probably why most people are very vitamin D deficient. The other thing I notice is African Americans who come to see me, doesn't matter, their vitamin D levels are really low relative to Caucasians. They're just really, really low because they can't convert the vitamin D through their skin or the sunlight from their skin into their skin and convert to active vitamin D. So those under 50 years old should take about 400 to 800 international units per day. And if you're over 50, 800 to 1,000. I usually tell most of my patients to take 2,000. The reason for that is I find 800 never works. It never, when I measure blood levels, I never get them up high enough. 2,000 never makes anybody go too high. To make someone vitamin D overloaded, so to cause hypervitaminosis D, you have to give someone like 10, 20,000 international units every day for a really long time. And even with that, those high levels may not cause any harm. So 1,000, 2,000 is not a lot of vitamin D. And that's why when you ask about the calcium with D, most calcium tablets have about 200, 400 international units of vitamin D. So if you take 2 a day, you're getting 400 or 800. That's still not going to be enough for most adults to keep them normal through the whole winter time. So you have to supplement with another 1,000 units. If you supplement with 2,000 extra, you're not going to harm anything.
So what is a reasonable time to be outside in Ohio?
Yeah.
A day or a week? What's the...
Well, I mean, if you went out to try to get natural vitamin D formation through your skin, you only have to go out for like 10 minutes without sunscreen, because more than that's silly, because you don't want to get melanoma, you don't want to get skin cancers, right? And actually, there was a recent study. Somebody said, well, what happens to people who use sunscreen compared to those people who don't use sunscreen all the time? And they looked at a whole bunch of people over a long period of time, and they said, if you use sunscreen, your skin doesn't wrinkle very much, you'll look a lot younger. So, you know, you have to be careful. Quite honestly, if you have all things being equal, I'd say use the sunscreen, go to Kroger's and buy yourself vitamin D. Protect your skin. Calcium, you need to absorb it, so you need the vitamin D to do that. If you lack vitamin D and your vitamin D levels are low, then that calcium that you're taking in does not get absorbed, because you need active vitamin D to do that. You also need active vitamin D to take the calcium and the phosphorus and to build good bone, because bone just doesn't sit there. It's not like a brick in your body. It's always getting taken away, rebuilt, taken away, rebuilt. So it needs the appropriate nutrients, the appropriate amount of calcium, phosphorus, vitamin D, in order to take some away, but put it back as best it can in order to protect your skeleton. When we measure vitamin D levels, most experts would say you need above 30. Institute of Medicine, which is this big guru group, came out last year saying above 20 was okay, but most bone experts feel that 30 is better, 30 is more appropriate. But I would say at least if you're in the mid-20s and above, you're probably going to be okay. But if you're going to take supplements anyway, you might as well shoot for a level of 30 to 40. I think that's an appropriate level, but it's hard to achieve. I tell you, I give a lot of vitamin D out. I don't know if patients just don't like to take it or what. Yes, ma'am. Yes, the vitamin D gets stored very readily in your liver, and so once you build up a lot of it, it lasts for some time. So that's why you only need the pills really kind of once in a while if you took enough of it, sunlight once in a while to build up those levels, because they don't just disappear real quickly. They're stored very well in fatty tissue and in your liver. Not a lot of foods have a lot of natural vitamin D. A lot of things are fortified like milk, but milk isn't fortified with enough vitamin D probably to get our levels up to about 30. Plus you'd have to drink a gallon of milk or 2 a day, and nobody's going to do that. Many of our orange juices and cereals are also fortified, but it seems like no matter what, it's very hard to get a vitamin D level above 30 just from diet alone. At least in Dayton, Ohio it is. And it's not like vitamin D is real expensive. I mean, everybody must get the Sunday paper, right? So if you look at the Sunday paper, what is there? There's 30 ads from different pharmacies around, and every other one has buy one, get one free vitamins. So you can buy 6 months of 2,000 international units of vitamin D for $7, because you can buy one, you get one free, and they're like 90 pills, and you get 180 pills. The hardest part is remembering to take it every day. Exercise. So that's really good for people, because it does, again, it pounds your bones a little bit, helps you rebuild stronger bones when it's turning over, so that's all good. It enhances your muscle strength. For everybody then, and especially as people get older, it helps them with balance, strength, so that they're less likely to fall. It improves cardiovascular fitness, which is really good. So everybody should do something. And if you had, Let's see if the next slide's right. If you already had established osteoporosis, you have to be a little bit more careful. You can't just go, riding your bike, because what if you fell off? That's not maybe a great idea. You can't go for a giant run, because what if you tripped and fell? But you should do something that's reasonable for your age. And if you're really not sure what that is, you can go to a physical therapist, and they'll give you some guidance on weight-bearing exercises that are not overbearing. Or you could just use common sense. You could walk around, you could do some light weights, and all that would be better than sitting on the couch and watching TV all day long. Goes without saying again, alcohol abuse, people have problems with their bone density. Smokers tend to have lower bone density as well. Treatment. So, yes?
Is there I have 2 stress fractures. I have one in my tibia and one in my fibula. Is it possible I got those stress fractures from over too much weight on my bone?
Stress fractures are tough, but it's usually not osteoporotic, osteopenia stuff. And they're not really well known as to what caused it. It's probably just stress fractures from the stress. So if you exercise a lot or run a lot, that's how people tend to get them. And some people are just unlucky. But I see some people who are younger come to me for stress fractures, and we try to figure out, well, what's the cause of this? And you usually don't establish a good cause. So I think it's more luck than it is most anything else.
I just had a bone density test done 2 weeks ago, and I'm just in the osteopenia, just barely. And my doctor suggested not only calcium and vitamin D, but magnesium. And what are the safe levels for that every day?
Well, magnesium is one of these, well, it's a mineral that if you take a little bit extra, it just gets peed out. So you can't really take too much magnesium and hurt yourself. And typically everybody has normal magnesium levels. Your body actually maintains them in a very tight range. And most foods have some magnesium in it. So it's unlikely that taking extra magnesium is going to be overly beneficial to protecting your bones, but it's not going to be harmful to you on the other hand.
And then on the other side of that, I know you're getting into the drugs part of it, but they're offering Fosamax. And Fosamax is something that I question about.
Yeah, and so the question is, if you just have reduction in bone density, should you go on medicine to prevent it from getting worse? And that really depends on the age of the person and other risk factors. So there's some people who, and the majority of younger older people, so in their early 50s or so, who have some reduction in bone density should not be on medicines that early, because no one would advocate that. And the reason for that is their risk of fracturing is very dependent on your age. The younger you are, even if your bones are a little bit crummier, your risk of fracturing, the architectural structure of the bone is typically strong enough where you just don't fracture. And I'll allude to that in a second.
So right now, without being too personal, but they're saying I'm at a minus 1.3, which is just...
Yeah, minus 1.3 is really minimal.
She wants to start me on that, and I'm thinking, with all the risk factors and everything involved, I'm just not sure I'd want to. I'm just wondering if increasing everything would be enough.
Well, there's a lot of factors that go into maintaining your bones, and you have to do all those right things with, weight-bearing exercise, calcium, vitamin D, and then you just have to repeat it. But there's no way that someone in your age group should be on, so that's just too young to be on that. And I'll tell you about how you figure that out in a second. So, now it's really, yes, ma'am.
I just have a quick question. If someone has had hip replacement, are they less likely to have a broken hip?
So if you have
Hip fracture, I mean.
well, the other hip's very likely to fracture. So that's why if you've been identified with a fracture, osteoporotic fracture, you should get treatment to prevent fractures at other sites. And that's unequivocal. There's no question about that. And one of the sad things that's very true is that people who break a hip end up with a hip replacement very rarely get put on medicines within the first 6 or 12 months after they have had their surgery. So why that is? Well, a lot of times it's just the system of medicine. You go into the hospital, you had your hip fracture, they fix it, you go to a rehab place, you may or may not go back to your primary doctor for a while. If you do, you forget about your hip fracture in some ways and you're talking about something else. The doctor may never be aware that you had your hip done, and therefore they never get the bone density and they never get you on therapy. The real solution would be to try to get people on treatment as soon as they break their hip, very soon after, and it doesn't happen. Very few people do, actually. Within a year of breaking a bone that's considered an osteoporotic fracture, only about 30% of people get placed on medications, which are known to be extraordinarily effective. So if you look at medicines like the heart medicines, the statins, like a lot of older people take statins, and they do lots of studies, right? They take groups of people who've had heart attacks or are at risk for heart attacks, half get a statin, half didn't get a statin. And then what they see is that, oh, you get a reduction of heart attacks by about 25% compared to the non-treatment group, and that's pretty good. You reduced it by 25%. But you know these medicines for osteoporosis decrease your risk factor 50 to 60 to 70%. Huge decrease. It's not equivocal. It's not just a little bit. It's a huge risk reduction for patients who have osteoporosis. And that's why it's important that your bone densities get checked, that you get treated appropriately, because you can actually reduce the risk of fractures tremendously. Well, you have to stay on it for a couple years, and then you see what happens, because some people will actually get so much better they may not need it after a couple years, but those people who are so severe may have to stay on it indefinitely. And then there's a couple other things that have kind of come in full circle where some people who are on the bisphosphonates for a really long time start to get atypical fractures. So they break a long bone and it cracks, and it seems to be a little bit brittle. And they think it's related to the bisphosphonates, which are helping reduce the fracture risk at the hip and the vertebrae, but then you get a funky fracture somewhere else. But still, the overall risk reduction of breaking that hip is markedly reduced compared to the risk of having an atypical fracture. So, who should get treated? Well, postmenopausal women and men over the age of 50 should all get fall reduction, modify those risk factors, do the weight-bearing exercise, do the appropriate diet. So that's like a no-brainer. That's really free stuff. You should do that. It's not a big deal. You initiate treatment on any postmenopausal woman or man age 50 or older who's had a hip or vertebral fracture. So if you had a fragility fracture already, you have osteoporosis by definition, you should be on therapy, because that's one of the definitions of osteoporosis. If you have that DEXA scan done and your bone density is less than or equal to minus 2.5, then you have osteoporosis, and you should be treated also, because that's going to reduce your risk of breaking those bones. Your case, perhaps, is like this, and that is, what if it's minus 1 to minus 2.5 of osteopenia? What do you do? Well, in the United Kingdom, somebody put together this giant algorithm from like all over the world, getting data from bone densities, your risk, and fracture risk over time. And what they found is the probability of fracturing is really related tremendously to age when you're in that osteopenic group. And so if you plugged in your numbers into the database, I guarantee you, you would not have a 10-year probability of greater than 20% of any site or 3% of hip fracture. So there's something called the FRAX algorithm that your doctors can pull up on the internet, plug in your numbers if you're in the osteopenic category to help choose whether or not you need treatment. Now, algorithms and stuff are good because they help you determine or help physicians decide on things, but sometimes doctors have to supersede an algorithm and make a good decision too. So there are some exceptions to the rule, which we won't have to go into. But if you're in that osteopenia group, you need to say to your doctor, what does FRAX say about my need for treatment? That's the standard of care. So let's talk about medicines then. So the medicines that are FDA approved currently are the bisphosphonate class of medicines. Calcitonin, as it turns out, is probably getting pulled off the market. This estrogen agonist antagonist called SERMs or Raloxifene or Evista is out there. Hormone therapy for women. Anabolic building bone. So this is something that builds bone. These decrease that turnover of bone, so you don't lose as much. So you build a little bit, but you don't take away. This anabolic is teriparatide, which is PTH hormone, which if you give it in a burst every day, and it's a shot, it can really build bone density tremendously and decrease fracture risk. So it's a great drug. It's very expensive. It's like $1,000 for a pen, and you have to use one a month. So it's a very expensive medicine. It has some association with some malignancies, I think, now. And the other thing is it doesn't work. I mean, it really just doesn't work very well. So if anybody said, oh, let's just treat you with calcitonin, you should say, no, I want something that works. Okay, remember that. Lastly, there's a new monoclonal antibody to a molecule, a receptor, that ultimately ends up building bone density or decreasing fracture risk and improving bone mineral density, which we'll talk about at the end. So the bisphosphonates are the medicines, and this is the generic name. So if we said, what's alendronate? Alendronate is generic now, but it is the old Fosamax. It was one of the very first medications out there developed. It's probably the best oral medication, the best pure scientific data for decreasing fracture risk, and now it's generic. Ibandronate is Boniva. Boniva has the least data that proves that it decreases fracture risk. In order for it to get FDA approved, they just had to prove the bones got better, the density improved. But they never had to prove fracture risk, and so it doesn't have any significant fracture risk data for it. So if you gave me a choice between this one and this one, while you could say, oh, Boniva's once a month, I think I'd like that, I'd go for the alendronate because that's a proven therapy, I think. Residronate's pretty good, too. That's under the trade name Actonil. That's a very good medication, too. It has a lot of good data. Intravenously, and why would you want to take it intravenously? Because some people don't tolerate orally, and sometimes intravenously is just more convenient, especially for the zoledronic acid, which is reclassed. Now, reclass has actually just gone generic in the last 3 or 4 months. So you can get zoledronic acid IV once a year and get tremendous lowering of fracture risk and improvement of bone density. So reclass is a great choice for a lot of people, but it's pretty expensive still. Yes, ma'am?
I had a reclassed infusion this morning, and I was on the phone making a dental appointment, and the dentist said, are you still taking that? Why? I don't know what the connection is. Is it to have to do with the bones in my jaw?
Yeah, and I'm going to get to a slide on that, which I hope will answer your question about the bisphosphonates and the osteonecrosis of the jaw. So, and the Ibandronate has to be given every 3 months IV. So again, if you have to choose between these two, you choose this one, which is once a year, great data. If you had to choose these oral ones, I would go alendronate or residronate. And I guess I shouldn't really badmouth Boniva, or Sally Fields for that matter, right? But I'd say if you want to be a scientist, you got to look at the data. They don't have as good a data for improvement of bone density and decreased fracture risk. The problem with the oral medicines is some people do get some heartburn. These things get in your stomach, they slosh around, they could irritate your stomach and the lower part of your esophagus. So it's a little bit of a nuisance to take. You're supposed to get up in the morning, take your pill, a full glass of water, empty stomach, then you got to stay upright. Can't lay back down, take a snooze. You got to sit up and you got to wait 45 minutes or so before you can eat or drink or take anything else. So it does cause some irritation to the stomach. And then there's this, possibilities of irritating the esophagus so many times that you can induce changes that might predispose to malignancy. Well, bisphosphonates are a specific class of medication made to go into bone and made to improve bone density and bone strength. But a phosphate's just a generic, it's a molecule, it's a compound.
The chemical difference between phosphate and phosphonate.
Well, the bisphosphonate's a huge molecule, very fancy. Phosphate's just your PO4, simple thing that floats around in everybody's blood. Okay, side effects of the IV, which is uncommon but can happen in about 10 to 20% of people who've never been on any of the oral medicines that are similar. They can get a flu-like illness. They get achiness, chills, a little fever, might last 2 or 3 days. So usually I would say if you're getting the IV reclass, take 2 Tylenol, a big glass of water, get your infusion, another big glass of water, and then take some Tylenol for 2 or 3 days afterward to minimize those side effects, which most people just don't report those to me. I just don't see a lot of it, but it clearly happens in about 15 to 20% of patients who've never been on these medicines. And the good news is if you got it 1 year and you didn't feel so hot after it, the next year you're very unlikely to develop the same symptoms because you sort of get used to it. Your body only has to see it one time, and the risks for the subsequent achiness and myalgias or whatever goes down. But you do have to have good kidney function. You can't just give it to anybody. You have to have reasonable kidney function to be able to be treated with the IV medications. Osteonecrosis of the jaw is what this young woman was alluding to, in that some dentists are really leery about these bisphosphonates, and they say, oh, you know, osteonecrosis of the jaw is when you have a breakdown of the soft tissue of your gums, and it erodes through, and you can see your bone, really. And there's a certain definition, like it doesn't respond to therapy, has to be present for like 6 weeks, and then you would call it osteonecrosis of the jaw. And the risk is real, but it's very, very small. And typically, it was first noted in patients who were cancer patients who were being treated with these bisphosphonates IV, and then they had a higher risk of developing this osteonecrosis of the jaw. But you don't really see it too often, and it shouldn't dissuade you from getting treated. Now, if you've had osteonecrosis of the jaw, you probably never want to be on these again, but that's not the case with the majority of patients. So it's a low risk, but it's something. The American Dental Association came out with their own statement about this. They said the risk of fracturing and taking people off the medicine supersedes the risk of osteonecrosis of the jaw. But still, many dentists are very leery of working on people's teeth. If you were going to get one of those IV medications and you're going to get your dental implants the next week, get your dental implants, get all that stuff taken care of, then get your medication. Don't push your luck, okay? Just get your, if you have some extensive tooth problems, gum problems, get it all taken care of, and then go for your IV infusions and your medications. That would be the prudent thing to do. Let's see, what did I do here? So it's really a low incidence. Most of it, like I just said, it was mostly in cancer patients, but it can happen with even the oral medications. It's just very, very uncommon. The atypical fractures are people who have fractures in the long bone of their femur. So you get a little hairline crack that hurts a lot, and then you usually have to stay off your leg for a while. And that's in association with the longer you've been on these bisphosphonates at higher doses, you're at a little higher risk for that. But still, the absolute risk is really, really low. The relative risk is real, meaning it's possible the longer you've been on it. But if you look around how many people are really getting it, very few. And it seems like the benefit of decreasing your risk of breaking your hip outweighs the risk of worrying about an atypical fracture. Calcitonin, it's nasal spray now, really crummy. I think it's being pulled off the market. I would never use it in anybody. If you have to be on something, this isn't what you want to be on. Evista or Raloxifene is sort of a niche product. It's one of these special estrogen agonist antagonists, and it's used primarily in women because what it does is it helps your bones but doesn't cause problems with your breast, and it doesn't cause problems with the uterus, with uterine lining. And it helps, but it's not a great treatment. It really has no benefit if you have osteoporosis at your hip. It helps in your spine, but it really doesn't decrease hip fractures. So it's sort of a niche product, and that woman who needs something else added on perhaps and who's a high risk for breast cancer, because this medication decreases the risk of breast cancer. Selective estrogen receptor modulator drug. So it can be used for the prevention and treatment of osteoporosis. Again, it doesn't work very well at the hip, so you wouldn't use it just for that because it's not going to work. It's great for patients who are at increased risk for breast cancer. It really reduces their risk for breast cancer. It's taken once a day. So it's sort of a niche product. I don't use a lot of it. I don't think OBGYN even uses a lot of this medication. Side effects, because it has that estrogen component and you're using it in older women, it does increase the risk of blood clots. The other thing, if you're sort of not real far away from menopause and you start using this, you can bring out the hot flushing again. So then you're not really a favorite of that woman anymore if she's hot flushing all night long. Teriparatide, which is Forteo is the name brand, is an anabolic agent, completely different than the bisphosphonates, helps build bone. And so if you look at how much bone do you get built out of, or percentage of an increase of bone density with a bisphosphonate, well, at the hip it's maybe 5%, and the spine maybe 8% at the most. Forteo is like 30 or 40% more. You just get much stronger, better built bones when you use Forteo. The problem is, it was studied in rats. In rats, bad things happen to rats when you give them drugs. And Forteo is an example. Rats who got Forteo got thyroid cancer, some of them, medullary carcinoma of the thyroid, which is a very unusual thyroid cancer. So consequently, they say you can only use this for 2 years in adults. So it's very unique. You can use it for 2 years, get good build out of it, but you can't use it for longer, all because of rats. Because of the receptors in the rat's thyroid, unfortunately, it predisposes them to problems. But it works great. And I frequently would choose, and someone asked the question, can you be on these medicines forever? A lot of times a great strategy is to use the bisphosphonate for quite some time, stop it, maybe use Forteo for 2 years, and then come back with the bisphosphonate again. That way you're getting different mechanisms to build bone in those patients who have a significant problem with osteoporosis. It's given in an injection, so once a day in a shot. And so you'd say, oh, I don't want a shot, right? It's horrible. Don't give me an injection. But you know what? You take the pen out, you put a little needle on it. They're really small, they're very thin, and you make the patient take that shot in front of you the very first time, and what they find is it doesn't hurt at all. It's very simple. The needles are ultra sharp. You can't push them in too far because it stops when it hits your skin, when the syringe or when the pen hits your skin. Very easy to use, and people go for that right away then because it's a very good agent. Very expensive though. And if I saw someone with osteoporosis and I said, oh, I think you should be on it, the insurance company could block it. The insurance company may say, no, that person needs to be on, Alendronate for a year first and prove they can't take it or have side effects from it before you can choose it. So insurance companies sometimes dictate what we can use first or second, or at all sometimes. Newest medication is Prolia. It's a monoclonal antibody, which means it has to be injected. It's injected every 6 months under the skin. It goes to a special site that interrupts the way bones get turned over, so bones kind of get stuck in the building mode and the takeaway mode is decreased. So it works like a bisphosphonate, but through a little separate mechanism. It's very good for decreasing fracture risk, and it doesn't rely on your kidney function. You can give it to anybody with any kind of kidney function, but it's a shot and it's fairly expensive, and so it's harder to get your insurance company to approve it. But it's a good medicine. Denosumab indications are for osteoporosis for women. It's actually FDA approved now for men. And of course, any of these medicines, like the bisphosphonates or the Prolia, or you cannot give to patients who have low calcium levels because it might make it lower. So patients have to be on calcium, vitamin D, have to have good calcium levels before you treat them. Follow up, what do? Well, if you have them on therapy, you watch them. Make sure they're doing all the right things, avoiding falls, good bone health, taking their medicines, and then repeat the bone density. When? Well, you could theoretically do it at 1 year, but 1 year's bone changes are really slow. It's almost not cost effective to do it at 1 year, but certainly at a 2-year interval to see what's happening is very reasonable. See if the bones are changing. Is that density getting better? Because you'd like it to get better. Now, if it doesn't get better, does that mean the stuff doesn't work? No, because even if it doesn't get, as long as it doesn't get worse, the fracture risk is going to be reduced by most of these, in most studies, with the bisphosphonate. So in summary, as I've tried to tell you, is osteoporosis, at least early on, is very silent. It's very common, so it's very prevalent. A lot of people out there, and again, if you figure that if you're over the age of 50 and you're a woman, you have a 50% chance of having an osteoporotic fracture. That's huge numbers. And it has dire consequences. If you break a hip, you might never walk again. Might never be autonomous again. It's really, really bad. We try to do things that are good for ourselves with diet, exercise, vitamin D, calcium. The older you get, the more important fall prevention is. Even risk-taking if you're 55 and you had osteoporosis, you don't want to do it. You don't want to be a skydiver maybe. Maybe you don't want to ride your bike at 100 miles an hour. You don't want to fall. We use the DEXA scan for the diagnosis. It's the best single study out there. And we have a lot of effective therapies. And the therapies are very effective, and people really need to be on them. So it reduces those fracture risks 40, 50, 60, 70% in some cases. So they're very effective medications. So I think that is it. Is there any questions? Yes, ma'am.
What exactly does DEXA stand for? Because sometimes it's DXA.
Yeah, these slides say DXA, DEXA, or DEXA. It's dual X-ray absorptometry is the name of the study. But yes?
So I go every year to
Well, I think it's this way, and here's what happens. And you know, so you could say, oh, these family practice guys are primary doctors, they're just not on top of their game. But you know, when they have a 20-minute appointment and you're coming in for your physical, and a lot of people come in and they have their diabetes and they have their high blood pressure and their toe hurts today, and you're trying to do all that, sometimes things get pushed to the back burner, one of which I think is very commonly osteoporosis just doesn't get thought about. But you're right, you should. Now you know it. Next time you go see your doctor, if you're over the age of 70 as a male, you should have a bone density done. That's right. I don't know who you want to blame. Maybe you should have come to this talk a couple years ago. Well, DEXA scans are really easy. So it's an X-ray machine kind of that you lay on a table. Thing just scans over you in like 2 or 3 minutes. Then his sidearm comes up and looks at your hip. Doesn't hurt. It's really low radiation exposure. Nicely reproducible if you get the right technicians and the right scanners. Very, very nicely accurate. So it's very simple. It doesn't hurt. It's quick. Yeah, rheumatologists and endocrinologists do a lot of treatment for osteoporosis, but again, if you have whatever the numbers were there, 20, 30 million people with osteoporosis, and we have 5 endocrinologists in Dayton, we can't see all the people who need DEXA scans or who need treatment. So your primary care doctor is usually kind of the first line of defense for assessing it, starting treatment. If they have trouble improving the bone density or you're not tolerating medicines and they need a hand, then they send them to the specialist. Yes?
How often do you recommend this DEXA scan or osteoporosis test for people?
Yeah, about every 2 years. Now, if you have a totally normal one, you may not need it for 3 years. Or if you've gotten a lot better on your bone density, maybe out 2 or 3 years. So typically, I would say every 2 years to start with, but then you could spread out the interval. Yes?
When you're talking about good diet being and risk factors, what does soda pop, what does that have to do with?
Well, it has a lot of phosphoric acid, and that interferes with calcium absorption a little bit. So that's what it has to do with. And anyway, people who drink a lot of soda tend not to eat as healthy. I think that's the other association. So I guess we're all doomed. No? Yes?
I have been on Fosamax for 5 years, and I
Osteopenia.
And then I was he said I didn't have to take it. Is that common?
Yes, because what happened was, you know, remember we talked about that FRAX tool. That FRAX, I said, it's this big thing you punch in the numbers into the computer and it says whether you're at higher risk for fracture. A lot of people many years ago were put on Fosamax based on, I think their bone density is not as good as it could be and I feel like they should be treated. And you could have been one of those. And then your bone density actually got a little bit better, and so then you really don't need it. So maybe if they had that FRAX tool before, you might have not been treated initially anyway. But that's not their fault. That's the change in the system and the new knowledge that's out there. Yes, sir. Well, you'll exchange calcium and sodium in the tubules, so you'll lose extra calcium if you take a lot of sodium in. But it's still hard if you're taking supplemental calcium. It's not like you can really make your calcium levels be depleted. You're not going to change your calcium of 9.5 down to 8.5 by drinking, you know, or taking in a lot of salt. It's just can happen that you'll exchange more, but I don't think clinically it will make that big a difference. Glucocorticoids are anabolic. So glucocorticoids interfere with vitamin D metabolism. They interfere with the absorption of calcium. They wreak real havoc with bones. Alcohol is probably related to the if you drink too much alcohol, you're just not getting the appropriate nutrition, and it has an effect, especially in men, centrally on their testosterone levels if you're drinking too much. And so it's sort of a multifactorial effect on reducing bone density.
What is the healthy way of increasing the level of testosterone?
Just doing, you can't really change it. You can do what's good. You can not drink too much. You can be healthy. And whatever it is, right? Not being too heavy. Men who are overweight as they get older tend to lose testosterone concentrations, fall more. So you can only do the best you can do. But most of that you can't really influence. Caffeine doesn't seem to have that significant an effect, no.
Now, something about the acidity of the stomach that is required for calcium to be
Absorbed, right.
So when people take Tums, all right, so you give it that calcium, but you take away that acidity.
Well, you're reducing the acidity, but you can't get rid of it as much. But if you're doing a proton pump inhibitor, you know, like Prilosec, and you're taking calcium carbonate, you will reduce your calcium absorption without any question, and that's why you need the calcium citrate. But calcium carbonate itself doesn't seem to have that effect. But that's one of the reasons why you want to take it with food, because you want your stomach to be pumping out extra acid to digest the food, and so you probably can never neutralize it all with the calcium carbonate.
But if you don't have any indigestion problems, you shouldn't take Tums as a supplement.
Well, but Tums is the same as like Oscal, so it's okay. So Tums is a fine way of getting calcium carbonate, and some people like it because they can chew it. It doesn't taste so bad, and it's cheap. You can get Kroger Tums, right? It's pretty cheap, so there's nothing wrong with it. So if you take it with your food, you'll absorb reasonable amounts. The problem with all calcium is you just don't absorb a lot of calcium. I mean, people absorb somewhere between 10 and 20% of the calcium they intake, and so that's why you have to kind of pump in a lot of calcium to get reasonable absorption. So even of that 1,200 milligrams you're taking every day, you're not absorbing 1,200 milligrams. You're not even close.